Good morning. My name is Natasha Oyedele, and I want to welcome you to the NIH Office of Disease Prevention's Methods Mind the Gap webinar series. This series explores research design, measurement, intervention, data analysis, and other methods of interest to prevention science. Our goal is to engage the prevention research community in thought-provoking discussions to promote the use of the best available methods and to support the development of better methods. Before we begin, I have some housekeeping items. You can submit questions during the webinar by clicking on the questions mark in the WebEx toolbar. Please direct all questions to all panelists. We will open the floor to questions that have been submitted via WebEx at the conclusion of today's talk. The slides and video recording will be posted on our website, prevention.nih.gov/mindthegap, in approximately 1 week. You will receive an email when they are available. Lastly, we would appreciate your feedback about today's webinar. Upon closing the WebEx meeting, you will be prompted to complete an evaluation. We would appreciate your feedback as it will help us improve this webinar series. At this time, I'd like to introduce Dr. David M. Murray, Associate Director for Prevention and Director of the Office of Disease Prevention.
Thank you, Natasha. Today's speaker is Dr. Max Crowley. Dr. Crowley is an Assistant Professor of Human Development and Family Studies at Penn State University and directs the Penn State Administrative Data Accelerator. He's a prevention scientist investigating how to optimize investments in healthy development. His work sits at the intersection of developmental science, social policy, and public finance. Dr. Crowley's program of research is motivated by a desire to increase the use of cost-effective, evidence-based preventive strategies to improve the lives of children and families. To accomplish this, his work aims to strengthen methods for economic evaluations of preventive interventions, optimize prevention strategies' impact, and develop best practices for how to translate these investments into evidence-based policy. Dr. Crowley translates his work for a wide array of policymakers on issues related to the impact and financing of prevention strategies. Recently, his research has identified cost-effective strategies for preventing opioid misuse through investments in schools and families. It is my pleasure to welcome Dr. Max Crowley.
Thank you, Dr. Murray. Appreciate the introduction, and appreciate everyone attending the session today. So as Dr. Murray mentioned, I'll be talking about investing in prevention and the opportunities surrounding it. In particular, just to give you a quick overview of what I'll be talking about before we open up for some discussion today, I'm briefly going to talk about some of the best practice or the consensus efforts for developing best practices for economic evaluations prevention programs that have been going on over the last half decade. Then I'm going to briefly talk about some of the opportunities for increasing utility of estimates for budget making, in particular surrounding different types of prevention programs, as well as then opportunities to include economic evaluations in your own studies. So taking a broad view, economic evaluation in federal research has arguably been growing over the last few years. In particular, we've seen a number of initiatives from the National Institutes of Health that have explicitly included different types of economic evaluations as a requirement for competition in both their grant funding as well as a key motivator for different forms of investment. For those of you who work in additional fields, you may be aware that the Institute for Educational Sciences now requires economic evaluations for multiple of its major grant mechanisms. The National Institute of Justice similarly is increasingly encouraging their grantees to pay attention to the value of upstream investments, particularly those that in the juvenile justice system for preventing a host of downstream problems such as recidivism. And the Administration for Children and Families has long supported economic evaluation as part of their work, both internally as well as externally. Of course, one example being the MyHope evaluation for the Maternal, Infant, Early Childhood Home Visiting Act and for evaluating the economic impacts of home visiting programs. So with that in mind, and just to give you a little bit of quantitative information, what we've been seeing is that NIH funding for prevention-oriented studies, in particular, have increasingly referenced economic evaluation methods explicitly in their proposals over time. In particular, we saw a sustained growth between the 2003 and 2009 period with some plateauing over the last few years, but the opportunities are much greater than, for instance, or the focus has been much greater than, for instance, in the 80s and 90s, late 80s and early 90s. So with that in mind, what I'd like to do is first talk about some of the efforts to develop best practices for economic evaluations of prevention. In particular, I'll highlight briefly some of the consensus efforts, and then I'm going to quickly drill down particularly on one set of standards that have been developed. But largely, previous to the work over the last decade, there was arguably a lot of fragmentation in the methodology for conducting economic evaluations, particularly of prevention programs where you're looking over long periods of time. As a result, we've been focused increasingly, and researchers in this area have been focused increasingly on how do we develop consensus around these best practices. So a number of these are listed here. In particular, NIH-supported efforts by the Prevention Economics Planning and Research Network, the National Academy's Economic Evidence for Investing in Children, Youth, and Families, the Consensus Panel, the Robert Wood Johnson-supported Second Panel on Cost Effectiveness in Health and Medicine. And what I'm going to focus on particularly today is the Society for Prevention Research's Standards of Evidence for Economic Evaluations of Prevention, most germane to the interests of many of y'all, as well as this the office. So with that in mind, I'm going to focus then on the SPR standards. I'll also call out some of the work of the Prevention Economics Planning and Research Network, which worked closely with the standards efforts. I'll talk about this a little bit more, but all of these efforts had a significant amount of coordination over time, and as a result, many of the best practices that were identified, even though they cross a variety of areas of health, medicine, social policy, actually do align quite nicely, and as a result, what we really have seen is this ability to start pointing to standards of evidence as well as just simply best practices. So just briefly, I want to thank the members of the task force. So in particular, my co-chair, Kenneth Dodge at Duke University. So the Society for Prevention Research's task force on standards of evidence for economic evaluation and prevention is part of its Mapping Advances in Prevention effort that is funded through an R13 grant to the Society for Prevention Research, as well as some of this work was supported by a parallel R13 grant from the National Institute on Drug Abuse to the Prevention Economics Planning and Research Group. So as you can see, some of the members, this was a multi-year effort and involved working with a variety of stakeholders. In addition to the consensus panels mentioned before, it also involved working with a number of key stakeholders in the policy and practice communities, as well as methodologists across disciplines. The picture in the back, for instance, indicates when the task force was invited to the Office of Management and Budget by Kathy Stack during the previous administration to work with a number of their officials, as well as officials from the Children's Bureau and a number of other offices around their not only the actual mechanics and methodological aspects of these standards, but the needs in terms of increasing the utility of those standards, which I'll talk a little bit more about. So briefly, I just want to give a quick overview of these standards because I won't be able to discuss each standard in great detail, but instead I've chosen a couple to drill down into to give you a sense of the focus and a flavor of those standards themselves. I encourage everyone, when you have a chance, to take a look at the recent publication that came out about the standards last year, and that is an open access manuscript, so everyone should be able to access it for free. So this Society for Prevention Research consensus effort resulted in 24 standards that were identified, as I said, over a multi-year process. They were adopted unanimously by the Board of Directors for the Society for Prevention Research as standards for the field of prevention science, and both the journal of the same name as well as other groups have increasingly been adopting and implementing examples of implementation of these standards. Further, the task force coordinated with other efforts, as I mentioned, and as a result, this resulted in six standards categories. So those included standards for framing and economic evaluation, standards for estimating costs of prevention programs, as well as valuing the effects of prevention programs, standards for summary metrics, standards for handling estimate uncertainty, as well as standards for reporting economic evaluations. So for today, I'm going to focus on two of these categories and standards within those categories in particular, in an effort to provide some illustrative examples and, again, give you a sense of the efforts that surrounded this standards work, but of course not being able to provide a fully comprehensive overview. So in this context, standards for estimating costs of prevention programs, 5 specific standards were identified. Many of you who have had some exposure in this area before may be familiar with, for instance, the ingredients method developed by Hank Levin and Clive Belfield, as well as others. So there was a significant consensus around the opportunities from using that methodology in particular. That refers to standard 2 of this category. But today what I want to focus on is standard 3, in particular, the need to describe comprehensively the units and resources needed to implement an intervention, as well as disaggregating it by time. So in addition to, for instance, what many folks have recognized as best practice in terms of using an ingredients-based method, this particularly pertains to prevention programs. The importance of recognizing both time as well as the different resources needed to support program implementation of prevention programs, which often are operating outside of existing infrastructure or formalized infrastructure. And so the need to focus on not only the direct implementation costs, but the infrastructure costs that surround them become particularly important. So with that in mind, I'm going to use an illustrative example today of the Prosper Prevention Delivery System. Some of you may be aware of this program, but for those of you who aren't, this is a randomized control trial. This was a system that was evaluated within a randomized control trial of 28 communities in Iowa and Pennsylvania. It delivered universal school and family-based prevention programs to the intervention sites and supported the delivery of 6 cohorts of services that reached over 15,000 youth. There's a substantial literature here led by Dr. Mark Greenberg, Dr. Dick Spode, Dr. Mark Feinberg, as well as a number of other key researchers that have highlighted demonstrated reductions in substance abuse prevention, or the prevention of substance abuse, as well as more recently the prevention of other forms of delinquency. One of the things that makes this a particularly valuable example was the prospective and thoughtful consideration in tracking budgetary and non-budgetary resource consumption. When I say non-budgetary, I'm particularly, of course, referencing, for instance, in-kind and volunteer costs. And this was an artifact of the Prosper Prevention System's particular focus on understanding the adoption, implementation, and sustainability of universal prevention programs. And so it was ripe for economic evaluation and has taught us a number of different lessons about how we can be more strategic in terms of how we do cost collection so that we can do things like, for instance, understanding the costs of across time. And so this is just a quick visualization of the costs across cohorts for delivery. We're of course considering things like startup costs at the beginning, as well as in other fixed costs, as well as sustained costs across time. But even more to the standard 3 that I had mentioned before, the opportunity to not only identify the ingredients, space, personnel, material costs, but also link those resource needs to the resource needs to the activities of the implementation of the prevention program itself. Understanding the upfront costs of program selection, for instance, the cost of facilitator training, participant recruitment, the direct cost of program delivery, as well as fidelity monitoring and program evaluation. Not surprisingly, many of you who work in the prevention space are well aware that those costs, in terms of getting a program in place, they continue across time. For instance, you have turnover in facilitators. The costs, in project year 3 may not be as much as the startup costs in project year 1, but they're still there, and if they're not considered thoughtfully, then planning for future implementations can go awry. So I'm going to move forward and talk about the second category of standards, but I look forward to conversation. If anyone has questions, as Dr. Murray mentioned, there's an opportunity to submit through the comments forum. But the second category of standards is for valuing effects of prevention programs. In particular, today what I want to focus on is standard 1 of this category around estimating findings, the need to estimate findings for each program outcome separately from benefit estimates and describe the context of the evaluation. So this is a particularly important area, and again I'm going to use the PROSPER prevention system as an example and some of the work that was done there. In particular, first focusing on some of the cost effectiveness work, looking at the prevention system's ability to prevent adolescent opioid misuse through the end of high school. So Dr. Dick Spoth and Mark Greenberg and others identified the ability to prevent opioid misuse from the PROSPER prevention program. And then we went on to think about the cost effectiveness to prevent a youth from becoming a prescription opioid misuser. So first, common cost effectiveness analyses, for instance, look at willingness to pay threshold. So an established willingness to pay threshold in the literature for a prescription opioid misuser in adolescents is often considered to be around $7,500. This is just one willingness to pay threshold. Of course, there's other ways to define this. And so we can compare that PROSPER is its ability to prevent a new misuser for about $2,000. What this indicates, of course, is that there's uncertainty in this estimate, as you can see below. And growing on that, though, the PROSPER system also taught us that a combined school and family programs can be a particularly cost-effective option in that it can still be below this willingness to pay threshold, but can achieve greater potency or greater effectiveness, a greater reduction level. So the opportunity to optimize program implementation. But building on the need to understand specific areas and those values instead of a singular kind of estimate of a willingness to pay threshold, in this context $7,500, the importance of breaking out the value of those benefits themselves. So what the PROSPER prevention system in the literature surrounding it has done is actually we've broken out these different cost categories through different projection models. And we'll talk a little bit more about the opportunities between projection versus not projection models, but often in the context of prevention, we have to project because the time course to get to, for instance, the cost of the criminal justice system, labor market, or healthcare systems can be a fair amount off. And so in many cases, we do need to project out. In this context, we projected out across 3 different areas, 3 different domains, in accordance with the recommended standard above, and looking at not just the healthcare costs, but those labor market costs, right? The lost employment earnings, the lost taxable earnings from that, as well as costs of the criminal justice system. So taking, in the context of prevention, a broad view of health when we invest particularly in preventing risk and promoting different protective factors, we know that they're going to have ripple effects to a number of different domains. And in making it explicit where the value is to different sectors, we can better understand the value of work in this area. So one thing to point out in particular, because it'll have relevance later, and so just a number to hold in your head, when these projections were made, about 20% of the healthcare costs were expected to be, for instance, to publicly financed healthcare, specifically Medicaid. And so just something to keep in mind as we go forward. So in this context, now I'd like to transition from the conversation around some of the efforts to identify and develop standards and highlighting how adherence to those standards can provide a lot richer understanding of the value of prevention and moving beyond, for instance, for every dollar spent, $12 or $3 or $20 in return, and thinking about the rich sort of information that comes from these types of analyses and these types of methods. And so I'd like to kind of pivot or expand, if you will, on this idea of increasing the utility of estimates for budget making. In particular, this draws on some of the work of the National Academy of Medicine and the consensus panel around developing recommendations for economic evaluations of children, youth, and families. I highly recommend it. Another free resource entitled Advancing the Power of Economic Evidence to Inform Investments in Children, Youth, and Families. As part of this consensus panel, we identified a number of opportunities to increase the utility of estimates, particularly for budget makers, and they align with some of the efforts around standards and pushing the field towards higher quality analyses, but in particular, the idea that cost analyses should include administrative records of budgetary expenditures. So many of you who may have encountered economic evaluations are aware that a lot of cost analyses do rely on existing budget information. And we often encourage those to go further and consider the opportunity costs and the costs, the in-kind or volunteer costs, non-budgetary costs that might be required, particularly of prevention programs. But one area to emphasize is that those administrative records of budgets provide really key information to the decision makers who may decide to invest in prevention programs. And so providing a really clear understanding of what the budgetary cost will be to those stakeholders of delivering different prevention programs is really key. So making sure to have a wide understanding of costs, but also pay attention to the actual expenditures, not necessarily a purely projected expenditure, but very clear actual expenditures. Further, the outcome data itself should include variables with meaning to policy and practice communities. So with this in particular references the need to evaluate the impact of our programs on outcomes that have direct value and implicit value even to policymakers or practitioners. So these are commonly referred to as things like reduced diagnoses, service use, reduced special education, increased graduation, reduced criminal behavior, increased employment. Each of those categories have, if not a clearly monetizable value, an implicit value to most individuals. They understand what those outcomes are. Now, there's a real conundrum in the area of prevention in that we struggle to often directly observe those kinds of impacts. And that's understandable because many of our prevention programs, it takes many years before our populations actually are engaging in service utilization or are graduating from high school or college or whatever it may be. And that requires us to think strategically about what our outcome measures are. In many cases, we select proximal outcomes, often evidence of reduced risk for some certain negative outcomes or the promotion of certain positive outcomes downstream. And that's an excellent way to do it, and clearly a necessity of the field. One of the things that we can do to increase the utility of these estimates for budget makers is to be considerate of how those proximal outcomes, whether or not they actually have direct meaning to, for instance, the budget making or policy making practitioner communities. And in doing so, we can have a lot clearer value for those practitioner and policymaker audiences. Doing so often means looking at the proximal outcomes that have a clear, direct link to some of these more distal outcomes. That's one way of doing it. So it's one way to consider doing it. Another limitation, in addition to the time span, of course, is also the power of our evaluations, the statistical power, and being able to detect differences, for instance, in our intervention, in our trials, on these outcomes that could be lower incidence use cases. In those contexts, the opportunity to understand how we can develop trials that are larger in scale, but we can then rely on, for instance, administrative records to be able to document those benefits, reducing the data collection costs and allowing us to focus on implementation costs, or partnering with those who are already supporting implementation, state and local government, for instance, and adding high-quality evaluations, particularly economic evaluations, to them. So these are areas that affect all of the prevention field, not just economic evaluation, but they particularly resonate in those spaces, because without these distal outcomes, it's harder to value and monetize the outcomes that we care about. And finally, an important area to note in terms of the opportunities for increasing utility of estimates for budget making pertain to the uncertainty of estimates that should not only be reported, but we should have an understanding of what is driving that uncertainty. It should be unpacked so others can make projections based on your findings. So this can be be thinking about what is driving the uncertainty in our models on not only the effectiveness side, but also the cost side. For instance, there are many market forces and market dynamics that impact the cost of personnel time to actually implement our programs. For instance, in the case of areas of the country that are still experiencing nursing shortages, and as a result, it's much more costly to hire nurses in those domains, or excuse me, in those geographic areas than areas where there may not be a shortage, then in turn driving up the cost of the program. On the other side of the equation, we should be thinking about how the uncertainty in our effectiveness estimates are following through in terms of the uncertainty then in our monetized benefits when we do such analyses. Doing so is important because when we fail to include that uncertainty in those estimates, we give an impression of false precision in those estimates, which the field already suffers from because these analyses lend themselves so well to really nice sound bites, such as the benefit cost ratio. For every dollar spent, X number of dollars in return, not really considering the uncertainty in those estimates. And so the need for all to be considering that is important not only for the integrity of the field, but also to provide quality estimates for budget making so they can build that uncertainty into their models, and so from an actuarial standpoint, understand whether or not the projected, for instance, downstream benefits to public budgets are in fact going to actually offset the upfront investment. So one of the things I was asked to talk about today, and Dr. Murray mentioned in the introduction, was in light of the opportunities around administrative data to enhance the quality and utility of economic evaluations, was some of our efforts here at Penn State University around developing an administrative data accelerator. So the Data Accelerator was founded in 2015, and it facilitates the use of national, state, and local, individual, as well as aggregated administrative data from the healthcare, criminal justice, child welfare, and labor market data sources, particularly for health and social science research, with a particular aim to support benefit cost analyses and other forms of economic valuations. It was born out of this need to access high-quality administrative records and have those available and understand the processes for accessing and acquiring those data, in particular to understand the costs and benefits of different prevention programs. And so this is a really nice resource that we've been able to use to support a number of different NIH, Foundation, IES, and other federal proposals. In particular, both the data that's held within the accelerator as well as the processes and agreements that have been set up through the accelerator to access sensitive administrative data, link that data to existing trials, and then obtain estimates explicitly for economic estimates have really been able to facilitate our work. It's part of a number of awards here at Penn State, but we increasingly have been supporting researchers at other universities, about 7 now around the country, and we're interested in supporting more as well. So this infrastructure in particular allows researchers to access, link, and analyze key data. We particularly have worked hard to support the secure access, but not only that, thinking about the ethical ramifications of accessing these data, particularly for economic evaluations. Economic evaluations, when they're used for decision-making, can have important ethical ramifications that should be considered, and researchers should be considering them up front, both in terms of impact on trial participants, but also in terms of the larger impact of their science. And there's a lot of data out there that could be used, but not all of it should be used, is one argument that needs to be considered. And when it is used, it should be used with clear benefit. So, so one thing that we to kind of follow through on this example, looking at the PROSPER trial in particular, what we did is we mapped the 30,000 participants that are on that trial onto individual Medicaid records to understand the impact of PROSPER directly on expenditures to the Medicaid system. So I mentioned that we had a projection of what the PROSPER trial, what kind of cost aversion the PROSPER trial was likely to have achieved for the Medicaid system. And so what we sought to do was actually observe whether that was occurring or not and test it out. And what we found was we were wrong, actually, in our projection, but right in our hypothesis that PROSPER was having a significant impact on Medicaid spending in particular. And so, for instance, in the context of the trial, we had projected about a $500,000 savings from the Medicaid system, but what we saw was, in terms of the actual observed benefit that CMS actuaries can actually go in and look at, was more around the tune of about $700,000. And so this was, an important consideration, in the work that we were doing in terms of trying to understand not only were our estimates that they have utility, but what was the quality of our estimates. And in doing this and actually mapping the impacts of our programs onto public budgets, we can increase the utility of our estimates. Of course, that's not the entire purpose of economic evaluations. It's one role that economic evaluations can play in supporting the use of research in a number of different evidence-based practice and policy contexts, but it's a particularly valuable one that's coming online, as we've seen in many areas, millions of dollars invested in increasing the quality of administrative data, as well as in the healthcare context, we've seen billions of dollars spent improving and bringing different EMR systems online. And while that data is not perfect in all areas, it does have increasing relevance for conducting economic evaluations that both reflect the health impacts of our programs as well as the economic value. Okay, so to kind of wrap this up, I wanted to just identify in particular some opportunities to include economic evaluations in your studies, some take-home points, if you will. In particular, the importance of tracking budgetary and non-budgetary costs prospectively. At the beginning of your studies, you should be thinking about these as much as possible and setting up your systems so that you can passively collect this information in a way that isn't burdensome on the overall project. It's very important to pay attention to R&D, research and development costs, and keep them separate from your implementation costs as much as possible. Many of us will use personnel who will be part of the trial and will also be part of an implementation, and the need to partition out that time so we can get accurate cost estimates down the road. Further, the opportunities that are increasingly surrounding the work around consenting participants for linkage to administrative data, and knowing where those high-quality systems are and what kind of consents need to be in place, as well as when that's not possible to engage in that kind of consenting, randomizing a sample based on geographic or demographic markers that show up in these administrative data systems that allowed for a de-identified looks at administrative data systems and allow you to still evaluate and map those benefits onto those systems. Further then, in that vein, mapping impacts directly on the public systems, both in terms of service utilization as well as actual payment. One particular area to pay attention to for us in the health space is not only looking at the payment data in terms of claims, so insurance data, administrative data in terms of the payment of the insurer, right, but also of the patient themselves, of the participant in the trial, and understanding those impacts is particularly important, as well as reporting findings in a meaningful way to a variety of stakeholders. So for instance, the work that we did with PROSPER in terms of mapping impacts onto Medicaid, while that has value to certain stakeholders who are interested in cost aversion to healthcare or in particularly publicly financed healthcare, that's not necessarily the main focus for all of the stakeholders who are interested in supporting that form of prevention. So the importance of recognizing that different stakeholders require different information, and part of creating high utility economic estimates from different types of economic evaluations is recognizing the needs of those different stakeholders. Okay, so my understanding is the slides will be posted online within the next week, and those slides include a number of resources, some of which I mentioned here, some of which are from other work. In particular, I mentioned I include the products of a number of the different consensus efforts that have been going on, and so you can have the opportunity to to peruse those at your leisure. In particular, I'll plug the standards of evidence down at the bottom here for conducting and reporting economic evaluations of prevention science, out now in prevention science, and open and available in an open access format. All right. My thanks to the task force and as well as NIH for funding much of this work. And I think we're right at time to start some questions.
Great. Thank you, Dr. Crowley, very much. We have a number of questions.
Great.
A fundamental question as investigators in prevention research are pretty good at writing grant proposals to get support to develop the intervention, to put the intervention on, to evaluate the intervention in terms of primary outcomes, and they know how to do that, and they have a sense of what those things cost. If investigators want to add economic evaluation to their otherwise structured R01 application, what are we talking about in terms of added cost? Is it 10% more? Is it 20% more? Can you give any guidance?
Yeah, the costs of doing cost analyses, right? So so that there isn't a sort of firm. I hesitate to give a point estimate of the exact percentage, but I can say that an R01 proposals generally can sustain a reasonably robust economic evaluation, but some resources do need to be put towards them. Different economic evaluations can be done more or less efficiently. So a couple plugs. If a cost analysis is set up prospectively, it's a lot less burdensome, for instance, than if and it's for a new clinical trial or new prevention trial, and the cost analysis is set up for that first implementation. It's going to be a lot cheaper than, for instance, coming back on your your renewal after implementation is already done to try to do a cost analysis. So that's one way to reduce the costs. Another is, as I mentioned, the role of administrative data. It can be very complementary from some of your survey data collection approaches, and it's often can be much less expensive in terms of the volume of data you get. Of course, it doesn't answer all of the questions you have, so often it requires a multi-data collection approach, but the administrative data sets can keep those costs for the economic evaluation down, as well as provide other benefits, as I mentioned before. So with that in mind, I think that what we see is often, it is within that 10 to 20% range. It can go lower if depending on how sort of tight the implementation is. If it's a large multi-component program as opposed to a very tight and specified program, it can be easier to collect costs on that. And then also, if it's a program that's going to have these multi-system, multi-sector impacts, that's going to, of course, be a little more costly than a program that is very targeted and has a very that distal impact very quickly, if you will. So, and those quote-unquote hard outcomes.
So if I'm an investigator, and I've been doing prevention research for a while, and I've been evaluating a series of interventions to address different problems and doing that, and now I want to try to include economic evaluation in that work. How do I find a partner to help do that? Because as the PI or as the interventionist or as even the design analysis person, I may not know anything about economic evaluation. How do I find a collaborator to join my team if I'm not at Penn State? I can't look you up in the directory and call you. How do I find a collaborator?
So there's a number of different sources, and one, before I mention what those are, I do want to make a plug for a particularly important resource that NIH had released about maybe 2 years ago, and that's Notice 1625, clarifying NIH's priorities around health economics research. So NIH has specific interests when it comes to health economics research, and the most important thing to keep in mind is that it's the overall study, of course, needs to be about health, right? It's not just a kind of accounting or financial sort of analysis. And so that can inform where you go in terms of the type of individuals and partners that you're looking for. So it's of course great to find someone who's been doing this in the health or social policy space. They often will that's often where you will find good partners. I'll put one plug in for the Society for Benefit Cost Analysis, which has an excellent annual meeting, as well as has a number of folks, particularly those who are very mindful about the sort of programs that rely on public spending and sort of the public financing of programs, which many prevention programs are. So that's another great resource. You'll often find more people doing the types of economic evaluations that I was discussing today in schools of public policy than you will, for instance, in a Department of Economics. And so it's, even though we use the same terminology and rely on the same underlying theories, a macroeconomist is not necessarily going to be able to provide you with the insights that you're looking for. Of course, there are great ones out there who can, as someone who is thinking deeply about it from a public finance and a public policy and a budgetary impact standpoint, which is where a lot of that utility comes forward. So it's a little bit of a plug to look in those spaces as well.
Sources of data are of interest to people. You talked about the Accelerator as an effort to make administrative data more available. And as I listened to that, it sounded a bit like the efforts that have been underway for a while to access electronic health record data to provide data for outcomes and for process variables in studies that are embedded in healthcare systems. And it sounded a little bit like you were suggesting if people select units for their intervention delivery, like counties or other areas that can be linked administratively to economic kinds of data, that might allow something along the same line. Can you elaborate on that?
Definitely. So the work at the Data Accelerator certainly builds on the sustained efforts to bring EMR, electronic medical record data systems online, increase the quality and utility of those. So we're certainly benefactors of that. As I mentioned, there's other forms of data, of course, claims data in the healthcare space, but then in other areas, particularly as we think about prevention. But to your point, Dr. Murray, certainly thinking about partnerships with the areas that you're implementing your programs, partnerships with county government, partnership with state government in particular, can open up access to those systems for those populations that you're working with. There are ways to kind of, if you have national implementations, to access national systems, but the richest partnerships, I would argue, come from when you're implementing a program in a number of counties and you have county buy-in, or you're working directly with the Department of Public Health or Human Services in your state to be a partner in that evaluation, and they share their data, or you work with an analyst in those offices if they're well-resourced to get to understand that data and enter into a data use agreement or otherwise. The Data Accelerator is particularly oriented towards supporting those who want to understand the budgetary and economic impact of their programs, and so that's one area that we're kind of unique. But certainly this can be done, without that kind of infrastructure in place. And just to be clear, what we're seeking to do has been largely around making the process easier. We don't try to necessarily hold all of the data. We just try to map the processes to help researchers get access. So if you're looking, for instance, for how do I enter into a data use agreement with my state, health department to access a certain type of data, those are the type of resources that we're increasingly trying to make available to people.
As an example, how did Prosper link to Medicaid data for the people that were participating in that project?
Yeah, so that's a great example of when you can use when you can use existing geographic or demographic data, for instance, to evaluate a program in a de-identified system, right? So in this context, for instance, we were using de-identified Medicaid records to link so we determined that someone was in the Prosper cohort because it was the universal programs were delivered in schools in a geographic area, and we were able to map those Medicaid recipients, right, who were in that area and living in that area at the time, with the right age, and in schools. We were able then to link that to their Medicaid records without ever having to identify the individual, which is an important aspect of the ethical and sort of security concerns around these data, which is because it was a community-based randomized control trial, we knew the community, we knew the timing, and we knew the individuals, where the individuals would be. And in this context, because it was a universal prevention program, it was particularly valuable. That's not always possible when, for instance, you're working with more targeted prevention programs, and that's where thoughtful prospective consenting comes online, and the need to make sure that you're consenting them appropriately and accurately in accordance with what is needed to access that data in those systems. So that's one example.
Yeah, this does sound a little different from what we do in pragmatic trials involving electronic health records, where we're looking at the electronic health records for the individual participants that are enrolled in the project and abstracting data from those records to use in the evaluation of the intervention.
Yep.
It sounds like you were drawing data from another source, not on the specific individuals necessarily, because you weren't linking to individuals, but rather for the geographic area based on age or other indicators to try as much as possible to match to the participants who were receiving the intervention.
That's right, and just sort of to clarify, what is increasingly available in a number of different spaces is access to individual level but de-identified records, right? And so if there's the marker, for instance, living in this geographic area at this time, within this age group, for certain types of trials, that's one strategy. I would point to another, for instance, Kenneth Dodge at Duke University, co-chair of the Standards Task Force, his work around the Durham Connects, Family Connects effort, they've had some success in this space as well, where the randomization occurred in terms of the birth date, right? So the odd birth dates received a program intervention, and evens were the control group. And so that's another type of marker that can occur in these systems, right? All within a specific geographic area within a specific time frame. And so, that's just one strategy. But many of our trials, especially when they are prospective and you're still collecting data from those individuals, there's a lot of opportunity to just consent them appropriately. Many internal review boards at universities now understand the value of doing so, and there's a lot more clarity in how to do it. And particularly when we're doing it in the context of an economic evaluation, it really is the best way to map the economic impacts of the program directly on the public budgets.
Investigators preparing their grant applications always want to include things that are going to appeal to the reviewers and improve the prospects of being able to conduct the work. Is adding economic evaluation to a prevention research project a beneficial thing in terms of the review process in your experience? Is it a mixed bag? Do study sections have the right kind of people to recognize good economic evaluation when it's proposed?
So certainly study section, the culture and interest can change over time. But our experience over the last 10 years or so has very much been, there is a real interest in this. Prevention has always sort of built part of its sort of platform for why it should be considered on a kind of value-based model in terms of the investment upstream to prevent downstream costs. And the opportunity to kind of say whether that's real. I think appeals to a lot of reviewers. So I could say overall that's been our experience. Getting into the more technical aspects of it, I think that just like any sort of innovative methodology, there can be strengths and weaknesses of including it. If it's well executed, if it's clear, if enough space is provided and enough resources are provided to ensure the quality of the evaluation, then yes, I think that they are very well received. When it's either under-resourced or just under-described in terms of the reviewers can't really get a sense of why it's there, what's the rationale, how the logic model really feeds into these downstream not only benefits but economic benefits, that can be troublesome. So, as you mentioned before, having a expert partner be part of the evaluation can certainly increase reviewer confidence from our experience. But it does, while it's not a major resource cost, it does often require some additional data collection, some additional analytic time, and certainly you want to provide time to ensure that the investigative team is going to be actually producing product in terms of both manuscripts and conference presentations, as well as translating, for instance, these estimates into things like policy briefs and other dissemination products. So those are the type of things that can really enhance reviewer enthusiasm as far as we've been able to tell.
We have another question about the Accelerator. What kinds of collaborations are possible if someone reaches out?
Yeah, there's a number of opportunities, and it can be everything from just initial sort of consultative in that we're always happy to talk about the process. We seek to share materials in terms of maybe you're trying to, for instance, get that data use agreement in place with an existing government entity that may have access to the specific data that you're trying to work with. So everything from consultative in that context through, we do maintain a NIST 800-171 compliant enclave that allows us to hold HIPAA, FERPA, CREA, and CAPTA compliant data. And so we do have partnerships with other universities that allow us to engage in certain types of data sharing, de-identified or non-human subjects for the most part, as well as we also do maintain the ability to hold highly sensitive data in the enclave as well. So if you either have access and you're trying to, for instance, go through the process of linking it to other data, that's something we can support. So it really runs the spectrum on that front. Certainly, one of the areas that we're most excited to support is when people are seeking to undergo or undertake economic evaluations and use this data to map the impacts of their programs on a public budget. Those are particularly exciting prospects. For the most part, our favorite way to collaborate is, for someone to reach out and talk about maybe a grant proposal they're thinking about engaging in and be a collaborative partner. We generally don't operate as sort of a for fee or for service type group. We're researchers ourselves. Yeah.
We have a question about what resources exist for budgetary and non-budgetary resource tracking.
Mm-hmm. Yeah, definitely. That's a good one. So as I mentioned earlier in the presentation, Hank Levin and Clive Belfield and their group at Columbia have really pioneered efforts around the ingredients-based approach model. It was originally developed for programs being delivered in educational contexts, but they've broadened that model, and it's now something that you'll see in a number of different areas of health and social policy more broadly. So one really nice tool that they developed is the Cost Out tool, which is a free online web-based tool for tracking different types of costs across time, and it allows you to track both budgetary costs as well as non-budgetary costs. So that's one place I often send people when they're looking to get started in that context. I think that the sort of process of tracking non-budgetary costs in particular requires the input of the principal investigator and a deeper understanding of the program than can be just sort of set up in a general tool. But the general categories that I encourage all of you to consider, of course, are volunteer time, prevention programs, particularly those delivered in community settings, will rely on volunteer time, whether it's explicit volunteers or the additional effort that those who are involved would put in, the tracking of in-kind resources, donated services, for instance, and the need to track those as well. So those two, if you can get your hands around them, you can really go pretty far with your cost analysis. But prevention, we often rely on them, and we actually wrote a paper that recently came out in the American Journal of Community Psychology talking about when we don't accurately capture those non-budgetary costs, it often puts an unreasonable burden on new settings, new sites for implementation, because those resources weren't included in the cost estimate. We've led those sites to believe it could be implemented for instance, a lower cost than was expected, and that there's actually maybe an ethical breach of trust there. So we highly recommend that people think about those non-budgetary costs, and I'm happy some of the resources that are mentioned, for instance, at the end of the presentation can also direct you.
Methods people, and this is probably true for people doing economic evaluations as well, methods people often want to do research to improve the methods that they work with and use. Mm-hmm. So who supports methods research for economic evaluations?
That's a good question. There are mechanisms, out there, but they're often not explicit calls, right, for actually doing methods work around economic evaluation. NIH has had methods calls at times where one could make the case for it. The IES, the Institute for Educational Sciences, has a explicit mechanism for supporting methods work. But what I would really point to is that a lot of our methods are most successfully developed and demonstrated in the context of existing trials. So a lot of times we, part of our partnership when we come on to support an economic evaluation of a project is what we'll do is, we'll have an aim to do an economic evaluation, but part of that, maybe a sub-aim, is doing some methods development work, testing out different methods to see which one is, which are going to be the most effective, have the greatest utility, decrease uncertainty, that type of work. So that's often when we find kind of the most cutting edge methods work is in the context of R01 proposals that have an economic evaluation included. Not always the ideal way. I think we'd all love a pot of money to support that, but the reality is that economic evaluation is a methodology that is so close to the ground in so many contexts that developing new methods that are devoid of context is actually a good way for those methods to never get used.
What you're describing is certainly exactly my experience in doing methods research in lots of areas over the years. I don't think I've ever had a grant as an academic to do methods research specifically, but I've done it for decades, sort of in the context of the studies that I was working on.
I will say that I did have an F-32 that supported explicitly methods work on economic evaluations. So I could imagine others using training awards or professional development awards to support that type of work as well. Right. So I will put a plug in there. But I agree with you, Dr. Murray. That's generally my impression of how the work gets done.
I want to thank you, Dr. Crowley, very much for a very interesting presentation and a lively discussion here. We've had a number of questions coming in from our listeners, and you've done a good job in addressing them. I will turn back to Natasha now to wrap up.
Thank you, Dr. Murray, and thank you to everyone who participated in today's webinar. As I mentioned at the beginning of the webinar, we will be posting the slides and a recording of today's session on our website next week. You will receive an email with a link to the recording when it is available. Thank you.